welcome, and I'd like to thank everyone for joining us today for this IAPB WHO webinar. I'm Peter. For those who don't know me, I'm Peter Holland, Chief Executive of IAPB, and I'll be moderating the session. Just before I introduce our speakers, just a couple of housekeeping rules. So we will, Alarkos and Stuart will both give some short presentations, but we will have time for questions, hopefully quite a lot of time for questions and discussion. So if you have any questions, and we hope obviously that you have lots of questions, that if you could use the chat function for your questions, and we'll take the questions from the chat. If you've got any technical difficulties as well, use the please let us know in the chat and we'll pick them up there. So I'm delighted that today that we're joined by WHOeyes and Stuart Keel from World Health Organization. I'm sure they don't need any introduction. I will introduce them briefly in a moment, but they're going to give us an update on a series of updates really on what's going on in the World Health Organization's Vision and Eye Care program. And that'll cover, they'll tell us in more detail what they cover, but it'll cover things like the latest on specs, implementing the cataract and refractive error targets, and the range of tools they've been developing to support the implementation of integrated people-centered eye care. So I'm not going to speak for much longer. I want to hand over. So I'm going to introduce WHOeyes, who's the unit head of sensory function disability and rehabilitation at WHO, and she oversees World Health Organization's work on vision, hearing, rehabilitation, and disability. And we're followed by Stuart Keel, who leads the implementation of the work in the 2020 World Health Resolution on integrated people-centered eye care. So, Alarkos, over to you.
Yeah, thank you, Peter. And first of all, I really want to emphasize how pleased we are to co-host this webinar with IAPB and really to talk to all of you who are joining this webinar. And look, when now there were three points really that came to my mind for the introduction of this webinar. And the first one I would summarize with the word momentum. The second one I would summarize with the concept of collective action, and the third one with grassroots. And let me say momentum. And why momentum? Because really what we have seen over the last couple of years is that there is an incredible momentum for the agenda of eye care and vision. And of course, it was already, or they started a couple of years ago with the World Report on Vision, and then with the resolution on integrated people-centered eye care. And what really I would say this document of the World Report on Vision and then the resolution they make possible is really to create awareness about the need to mainstream vision and eye care in the global health agenda. But it didn't stop there, because there were also additional decisions at the UN level that was with an endorsement of the decision of the targets of the global targets on refractive errors and cataract surgery, but also the resolution, the UN resolution on vision that really make the case and create momentum for the integration and the mainstreaming of vision and eye care in the development agenda. And this has been only possible really based on the contribution of IAPB, but everyone really in the sector. So I really want everyone to feel proud, because that would have not been possible if the sector would have not moved really with this message of vision being part of the mainstream health agenda and vision being part of the mainstream development agenda. So for that reason, I thought the second concept was collective action, because it has been really based on that collective action. And of course, all these global frameworks and narrative at the global level would be meaningless if action would not happen at the grassroots level. Or actually, I would say, if they would not have then, at the end of the day, an impact in people's lives. And for that reason, we need really to work together with that spirit of collective actions to achieve exactly that, to make an impact, a change in people's life and at grassroots level. For achieving that, as you well know, WHO has been developing a number of tools over the last couple of years. Tools that really is the aspiration to have that impact at grassroots levels. And for that reason, WHO alone will not be able to achieve that. It will be only thanks to the support and, again, the coordinated and collective action of everyone, the driving force that will achieve that. And that is the objective of today, is really to navigate you through the developments that has happened related to those tools in the last 12 months, to provide to all of you entry points how you can contribute and continue contributing to that collective action. And then, as you said, Peter, also have enough time for discussion and answering questions in that direction. So I stop here so that Stuart will then introduce those developments over the last couple of months. And I pass to Stuart. Stuart, please.
Thank you very much, Alakos. So I hope you can see the slides and hear me okay. So I'll move on. So the purpose of the session today is really not to have a deep dive overview of all of these tools that have been developed. They were launched in a couple of years ago around the World Health Assembly, but really to focus on some key updates over the last 12 months and just spend the next 20 minutes covering off on a range of topics, not in a huge amount of detail, but covering off on a couple of key questions, including what is the update, why we think this is important, and also how you can contribute or support these efforts moving forward. And I wanted to start with a tool that is very familiar to most, and this has been around at WHO for quite some time. It's called the Eye Care Situation Analysis Tool, often abbreviated as the EXAT. And the reason why we bring this up today is because about 2 years ago, there was some major updates to the EXAT really to make it more in line with the integrated people-centered eye care principles. But let's just briefly look at, for those that may not be aware, what the EXAT is. It is a questionnaire-based survey tool to comprehensively assess eye care in a country and help support then strategic planning. It's used to answer a few questions, including what is the current situation, strengths, weaknesses, what are the priority areas that need to be addressed in the eye care strategic planning, and what are the possible activities to address these gaps. So since this revamp of the EXAT a couple of years ago, it has been implemented relatively widely. In green on the map here, you can see a list of countries that have finalised the implementation of the EXAT, including New Zealand, PNG, Ethiopia, Niger, Ghana, Bhutan, India, Thailand, and the Maldives. There's a number of countries that are currently implementing, identified in brown, the Philippines, Nigeria, Nepal, and Indonesia. And there are several countries that are planning to implement in the very near future, including Fiji, Samoa, Kiribati, Costa Rica, and Paraguay. So the key update on this EXAT tool is that this tool, the hard copy Word version of this tool, has now been converted into a digital format. So the content remains the same, but there are several advantages to updating to this digital format, in that the information that's included from countries is now standardized when this EXAT is completed. The data is then saved on a secure WHO platform that's always accessible to users. There's also a maturity score that's been included in the most recent version of the EXAT, and this is now automatically calculated for the different health system building blocks. And the summary data entered can then be printed or saved electronically. So there are several advantages to this new digital form, and encourage anyone that's thinking about supporting the implementation or advocating for its implementation, please refer to this digital format and get in touch with us. So how can you contribute? I think contributing in the same way that IAP members have been contributing in the past, which is really advocating for the implementation where it's needed. At the start of the new development of an eye care strategic plan, or for those countries that are planning to implement, to really provide technical support in its implementation. The next topic I wanted to cover is relating to a relatively recent advancement, which is the inclusion of eye care equipment within WHO's Priority Medical Devices list, which is called MEDEVIS. So we know the relevance of this is that essential ophthalmic equipment to manage even the most common eye conditions is frequently not available, particularly in the government sector in low and middle income settings. So this MEDEVIS database is an open access electronic database of priority medical devices to really serve as a guide for member states on the appropriate medical devices to include in their country level medical devices lists at the different levels of care, setting, and for the different health interventions that they're prioritizing. So for the very first time now, the eye care devices from a comprehensive range of interventions drawn from the package of eye care interventions that was published a couple of years ago have now been included within this priority medical devices list. So how can this be used? Really, a primary way in which this can be used is to advocate to include these eye care devices that are now in WHO's list within country level priority medical devices list, and also can be used when funding or requesting medical equipment to plan intervention, delivery, or health programs. Moving on now to another update, and this is an important update because it's a very recent update. And as of last week, WHO launched what we call the Vision and Eye Screening Implementation Handbook. So we know from the World Report on Vision, one of the key recommendations and that the sector is moving towards is really reorienting the model of care to build a stronger primary care to provide eye care. So in line with this, in collaboration with an expert group, WHO put together this very practical step-by-step guidance for conducting vision and eye screening at community and primary care settings. So within education settings, within primary level facilities, for instance. So this covers key evidence-based age groups for which eye and vision screening should take place. And this is in the neonatal period, the preschool age children, school age children, and older adults. And it includes information including the age and the time frame for screening, what are the resource requirements in terms of the equipment and also the human resource requirements. It also includes what's the protocol and the test to be carried out in a standardized manner, what are the red flags for referral, and information on the results and follow-up, as well as amongst other information. So the target end users are planners at the Ministry of Health, but also other public health planners, NGOs in this space, and also personnel in primary care facilities. So this is now downloadable on the webpage. Please take a look at this. It's only available in English at the moment, but we are working now towards translating this in the 6 UN languages, but also with support of other collaborators into Portuguese as well. So we hope to have these translations available in the next months. The WHOeyes app is the next update. And the WHOeyes app was launched on World Sight Day in October last year. The primary purpose of this app is to really improve population awareness and drive demand for eye care services that we know is a big challenge that we face. So this app, what is it? It's a free population-facing app that's available on iOS and also Android devices that enables members of the population to quite simply check their near and distance vision and also learn about how they can protect their eyes through a range of educational messages that have been included within the app. So it's available already in the 6 UN languages, but some updates is that coming in the next month, we will have 4 new languages available, including Portuguese, Polish, Farsi, and Vietnamese. And again, thank you for those that have reached out to us to support these translations. The app will also soon be available for download in China, and there's a number of new languages that we're also working on to include in the app, including Hindi, Bengali, and Urdu. So how can you contribute? So put simply, we want to get this app into as many hands as we possibly can within the population. So really, we would be very grateful for your support with promoting the app and disseminating the app, particularly when we have the new languages available as well. There's a range of resources that we do have at WHO to support this promotion and dissemination, including a QR code. We have a video, an information sheet that's available on the webpage. We also have a range of social media tiles, and also if there are any stories about the use of the app, case stories, they would also be good to feature this app as well. If there is interest in any other languages being included in the app, then please also don't hesitate to get in touch with us, and we would again appreciate your support in translating. Moving on to another topic now, which is a big topic that Alakos mentioned before, which is the 2030 global eye care targets for effective coverage of eye care. So I think there doesn't need to be much detail on what these targets are, but just as a refresher, in 2021, member states adopted or endorsed 2 new global targets linked to the 2 leading causes of vision impairment and blindness, which is uncorrected refractive error and unoperated cataract. And the targets themselves are a 40 percentage point increase in effective coverage of refractive error and a 30 percentage point increase in effective coverage of cataract surgery. So to give you an example, if we say in this very first report that we published in 2022, where we brought together estimates from about 60 countries, it was found that just over 1/3 of people who had a vision impairment due to refractive error had access to a pair of spectacles that corrected their vision so they no longer had cataract surgery. So we say only about 1/3 of people were covered. Then by 2030, we're aiming for over 70% coverage. So this is a quite an ambitious target that we're heading towards, and will become quite relevant when I talk about the SPECS initiative later on. But with these global targets, some key updates that we wanted to provide include the fact that we are in the process of working with our academic partners, in particular the Vision Loss Expert Group and the team at the International Centre for Eye Health, to produce new estimates and launch these estimates in October this year. So these new estimates will draw on a much richer data set than the initial report for well over 80 countries. We have data for these indicators. And we'll be doing some more sophisticated modeling and analysis so that we can produce estimates for every country for these two indicators. So we're in the process over the next 2 months at WHO of undergoing a member state consultation to get feedback from member states on these estimates to feed into this report that will launch later this year. But very importantly, and linking back to Alakos's point earlier, which is really bringing the eye care agenda to the broader health and development agenda, there's two important decisions that are made relating to these indicators this year, and that is whether or not they get included within WHO's universal health coverage monitoring framework, and also the monitoring framework for the Sustainable Development Goals. So it's an important year, and we'll be putting forward our case, of course, for the inclusion of these indicators. If they are included, again, it serves to really raise the profile of eye care in these broader agendas. One of the other action areas that we've been focusing on with these global targets is expanding the data sources in which we can derive estimates for these two indicators, and looking beyond the routinely collected rapid assessment surveys in the eye care sector, and also the comprehensive surveys that are often undertaken in higher income settings. We have integrated these indicators within the broader NCD WHO survey, which is the NCD survey. There's a module that has been created. But also this year, we'll be undertaking some pilots to see whether it is feasible to include the refractive error indicator within the existing tropical data survey platform, and in particular trachoma surveys. And we're linking up with some of the IAPB members and NGOs and also the London School to carry out this work. So how can you contribute? Anyone that has a data that they haven't contributed already to these estimates, there's still time. So if there's any recent surveys, or by that matter, any older surveys, even in the last 20 years, that you have access to, that you think we can calculate population-based surveys, please get in touch with us, as this actually helps us a lot with really expanding the data set and making more comprehensive estimates. For any future data collection efforts, I think it's very important that from the outset we think about how the data sharing agreements are in place, so that there is sort of a smooth transition to get the data to WHO so that they can contribute to this monitoring exercise. And also support for additional data collection efforts and surveys being undertaken to really bridge the gaps, strengthen the data in different countries, regions, but also in the younger population. So with this, for the last two updates, I just want to focus on two refractive error related updates. And the first one is relating to the Myopia Ed toolkit. And this, again, like the XSAT, is not a new tool, well, a relatively new tool, I would say. It was published in 2021, really in recognition of the growing problem of myopia, increasing prevalence in the younger population, the fact that this is driven by lifestyle-related factors, and the fact that prevention plays a very important role. So this toolkit, as a reminder, aims to support behaviour change that contributes to delaying the onset and slowing the progression of myopia, and improving awareness and health literacy more generally. There's two key components to this toolkit, and the first one is the most important, which is an evidence-based message library that has been created in a very structured manner to be delivered over a program, and also a handbook to support the adaptation and also the implementation of this population health promotion and prevention campaign. So some key updates on this front we wanted to go into, and there has been some good progress in country implementation in connection with WHO and collaborators in different countries, including China, South Korea, and also Australia. But to give you a flavour of some of the work that has been done, I wanted to focus specifically on the efforts of South Korea. Firstly, acknowledging our collaborators in South Korea at the NSAI Institute for Global Health, who I think also join us on the webinar today. So they have implemented an evaluation of the Myopia Ed program in their country. Firstly, they underwent an adaptation phase of the message content. They developed a lot of images as well. And they targeted two population groups, and that is the important group of parents of young children, where we can have an impact on myopia prevention, and also adults in their 20s. They sent out messages over a 6-month period using two-way SMS messaging, so quite interactive messaging as well, where people could learn more, people could ask questions, and they delivered this message campaign using the most common messaging app used in South Korea. So what they have done is conducted a 6-month pre- and post-intervention study, where prior to the intervention, they did an evaluation of the current awareness in the groups of a few hundred people, and what was the baseline for the behaviours that we're looking to change in terms of time spent inside, in leisure time, on near work activities, on screens, and also time spent outdoors. And then they did the same evaluation in the post-intervention about 6 months later to get an idea of what influence this may have had on the users of this program. So the results are quite promising and will be published in more detail soon. But some of the key results were that there were high rates of participation, low rates of dropout, and there was a very good satisfaction amongst the participants. If we focus on the results relating to the parents of young children, there was quite a significant impact on improving parents' knowledge about myopia in general, but then also quite a significant impact on the behaviour changes in their children. In the majority, increased their average daily time spent outdoors post-intervention, and also decreased the average time spent on near work activities during the leisure periods outside of school hours. So these results really show promise in expanding this further in South Korea, and show promise in changing the behaviours in which we're seeking to behave. So what we would say is it's great if there is support to implement or evaluate at various scales, whether it be in a large population, whether it be a smaller evaluation in different countries and settings. WHO is very happy to support this process in the adaptation phase, and also draw on those collaborators that have been working in other countries as well. Also, you can use these messages that are included within the Myopia Ed program to integrate into existing eye care programs. We know that health promotion is often something that isn't focused on heavily, so really building this area up within existing programs using these messages, particularly in school eye care programs, would also be a way to move forward. And the very last update that we give is on, but certainly not least update, is a brief introduction to a new initiative at WHO that I'm sure many of you have heard about, and I won't go into huge amounts of detail today, but it is the WHO Specs 2030 initiative. So this initiative was developed, of course, in recognition of the huge unmet need for refractive error services. We're talking about billions of people in need, and from our recent results, only about a third of them have access to a good quality pair of spectacles. We know that there's a huge amount of challenges that we face in terms of meeting that ambitious global 2030 target that I mentioned before. So really recognizing that a comprehensive approach is required, WHO, drawing off inputs from the sector, of course, have developed this WHO Specs 2030 initiative to really take leadership in this space, raise the profile of this issue, and leverage WHO's strengths in convening power, but also the connections with governments as well. The vision and the mission. The vision of the Specs Initiative is the Specs Initiative envisions a world in which everyone who needs spectacles has access to quality, affordable, and people-centered refractive error services. And the mission is simply to support countries with the achievement of that World Health Assembly endorsed target, which, as I mentioned before, is going to be no mean feat. So very briefly, to address the key challenges that are facing, us in increasing coverage of refractive error services, we have suggested a comprehensive approach that calls for concerted action amongst all stakeholders under 5 strategic pillars. And these are listed on the screen here, and they're in line with the SPECS acronym. And the first pillar is improving access to refractive error services. The second is building the capacity of human resources and personnel to provide these services. The third pillar is around education, improving education, health promotion, prevention, and also the demand for eye care services. The fourth is around addressing the cost of refractive error services, and the fifth pillar is around strengthening surveillance and research. So for each of these pillars, after various rounds of consultation with the sector and individuals and experts, we have then developed country-level desired outcomes that as a collective, we aim to achieve through the actions of this initiative and broader actions within the sector as well. So really something to strive for. And you'll notice a theme with these country-level desired outcomes, which is focused on really strengthening the provision of refractive and optical services within the public sector. We know also that a lot of work is happening outside the public sector, but a key focus here is really strengthening within the public sector. So I'm not going to go through each of these desired outcomes, but I encourage you all to go to the WHO webpage, and you will see these desired outcomes. There's a number of ways that you can get involved in this initiative that I'll go through in a couple of slides' time. But I encourage you all to take a look at these desired outcomes. We may adapt these as we move along, but we feel this is a good starting point for us to commence the initiative and to strive for. Briefly, in order to achieve these country-level desired outcomes, WHO will focus on 3 key areas of engagement over the next couple of years. The first one is engaging with the private sector. There is a major private sector contribution to this refractive error space, and we recognise without engaging with the private sector, we don't see much hope of reaching those 2030 targets. So they play a very, very important role. So we will be engaging in the specific private sector dialogues with different sections of the private sector to put forward some asks to the private sector, undergo consultation, and then try to seek meaningful contribution to help scaling up refractive error services, particularly in low and middle income settings. The second key area of engagement in the middle of the screen here is the WHO SPECS normative work. So this is where WHO, in its normal role, will draw on individual experts from the field to develop resources guidance to help support the implementation of these country-level desired outcomes that we saw on the previous screen. We've already identified a few areas of focus for the first period, which will be building on competency-based teams approach for refractive error and guidance on the legislative-related issues for refractive error. And the third area of engagement is the global SPECS network. So this is a network of stakeholders which is hosted by WHO to really promote collective and coordinated advocacy and action for refractive error. We will be developing specific work plans that members can contribute to, and we'll be aiming to develop and implement those over the next couple of years. So how you can contribute? Individuals can contribute, as I mentioned, to the development of the different technical resources. They can also play a very important role in advocating to strengthen the provision of refractive services in health systems, really drawing on the technical resources that are already published by WHO and those that are to follow. And you can visit the webpage to see the refractive error specific resources that are already available. In terms of the WHO hosted network, organizations and institutes can apply to become members of the network, and you can find out more about how your organization can become a member by visiting the webpage. And in terms of the private sector, representatives can join the private sector dialogues, and it's anticipated that registration will open in mid-2024. So please, again, keep an eye on the Specs webpage, but we'll also be doing some more dissemination and communication on this as the time comes closer. So with that, I just want to say that we also have a range of communication materials that are available on our webpage that you may not be aware of. Please use these tools as you see fit, promote them, translate them as you see fit. And with that, I won't take any more of your time, but just to say thank you for your patience. And now I think we have plenty of time for questions.
Stuart Alarcos, thank you so much for a great presentation. And if you have a chance to look at the chat, you will see how appreciated that's been, and the reactions that you're getting. So fantastic! Thank you very much. So a reminder, although I think everybody is realizing this, please do post your questions in the chat. We've got loads of questions. I suspect we won't get to them all today, but what we will do is we will capture all the questions and make sure that any that we can't answer directly in this session, we will get answers back to everyone. So please do keep asking the questions. And what I'm going to try and do is try and bring some of the questions together so that there are some questions which link together. So I'll try and group the questions as much as I can to try and cover as many areas as we can. Just a quick question, Alarcos, Stuart, will it be okay to share the slides after the session? Great. Okay, so we will. That's come up a couple of times. We will share the slides, and a recording of this whole session will be on our website after the session as well, so you'll be able to review it again. So I actually want to kick off with a question myself before I turn to some of the questions. So Alarcos, you talked about momentum and the momentum over the past few years, and I wondered if you could just quickly, from your perspective, this is a kind of two-part question, just give a sense of what you think the really biggest successes have been over the past 4 or 5 years in terms of iHealth, beyond perhaps some of the kind of formalistic global resolutions, which have obviously created momentum, but some of the things that's then driven. But then also thinking about the future, you're about to enter into the next period, the Global Programme of Work 14 that's coming up. How within that do you think we can maintain that momentum?
Yes, great. Thank you, Peter. Look, I mentioned at the beginning that what has happened in the eye care sector in a marvelous manner over the last couple of years is really this collective action. But also what has contributed really, and for that reason, congratulating everyone, because we are where we are with mainstreaming vision into the health and development agenda, thanks to really everyone and this collective action. But I think what has been also fundamental is that we have moved together with the narrative of integration that really is gaining also more and more momentum in the sector. And I think this message and this action around integration of eye care services into the mainstream health sector and the development sector is the major really achievement that everyone really is identify with it and will continue identifying with it over the next couple of years. And look, regarding the GPW14, and for everyone, so to know, WHO, that when we have a new Director General, of course, it comes with a new vision and for the organization. And we put that in paper in a document called the Global Programme of Work that describes this vision for over 5 years. And now we are entering into the second global program of work under Dr. Tedros. And I think what we will see indeed that this narrative of integration, of eye care being integral part of universal health coverage, that it needs to be part of the that needs to be part really of the health packages that are covered by insurance scheme in countries is what will be predominant in where the eye care agenda will come into this global program of work. And something fundamental, what also Stuart mentioned, is that the two indicators, if everything goes as described and as planned, will be used to monitor not only the eye care sector on its own, but it will be used and contribute to monitor the progress that countries are doing in moving forward towards universal health coverage. So again, it's really this message of eye care, integral part of the health agenda, integral part of UHC. What I also emphasize has been one of the biggest success, I think, over the last couple of years, that the whole sector has moved in that direction.
Brilliant. Thank you, Alakos. And I would just echo that point about getting those indicators into the measures of how we measure UHC and ultimately, hopefully, the social sustainable development goals. Only today we had an example of a government who we were approaching about reporting on eye health, who were questioning back, why should they do it unless those indicators were being used for those broader reporting? So it's a really, really immediate example of actually how important it is we get eye health into those broader indicators. Stuart, there was a lot of interest in some of the detail of what you were talking. We won't be able to capture all the questions, but we will feed them to you. But firstly, I wonder if I could turn to this question around data and monitoring, so that it essentially feeds on from that point about indicators, because obviously the important thing is that we can measure and monitor those indicators and the targets. And we've had a number of questions. I'm going to pick a couple from Celine Noguez and Joy Coetch. So their questions were firstly about how can we get a better idea of what the data gaps are and how they can be bridged and where we need to prioritize our efforts. And I think related to that and underpinning that is, how do we know, will you share the sources of data that you're already using so that we can already know, so we don't actually duplicate what you've already got?
Yes, thanks for that. That's a very, very important question. I'm glad that got picked up on. So in the first report that was published in 2022, and I think a link has been posted in the chat, there is a list of the data sources that we had for the first report, and there was covering about 60 countries. So that's from 2 years ago. But as I mentioned, we have updated the data source, really thanks to the efforts of the sector providing more data to these efforts. And now there is an additional sort of 100 surveys from another 20 or 30 countries. So in probably the next month, we will have that list consolidated after we have had this member state consultation, and then it would be a good opportunity to communicate this and share so that we can see the specific gaps. And there are a number of geographical gaps, as I mentioned, but also, the more general gaps that we see that we're trying to focus on addressing is this gap in the school-aged and working-aged population, which we know is increasingly important, and for the refractive error indicator in particular. So this probably brings me to a point that we have been working on, and we have mentioned this in similar forums, a survey methodology, a sensory function survey methodology, actually, that not only covers these two indicators, eye care indicators, but also incorporates two key hearing care indicators as well. And we are in the process of piloting that methodology at the moment. And we hope that in 2024, this tool will also be available to help support these data collection efforts.
Great, thank you. That's and this is obviously a work which we've been working with you on as well, and will continue to do so, because we recognise really how important it is. I want to turn to the tools, which you may have seen the reactions that you were getting as you went through about how appreciated they are. And again, there are lots of questions, and I'm afraid I'm not going to be able to cover off all the questions on the tools. But there was a theme to a number of the questions. So Noella Prasad asks around the alignment of EXAT with other similar tools within WHO, such as SARA. Bernadetta Shiloh asked around whether the vision eye screening tools were aligned with PEC guidelines. And Claire Gilbert had a sort of similar related question, which was around the mechanisms for equipment lists being shared between health sectors at WHO. And I think there's a theme here about understanding how do all these tools actually connect up, how they aligned, but also do they read across, as Claire's suggesting, into other areas, whether that's child health, neonatal care, diabetes, care of the elderly as well.
Yep. So I can start, Alakos, if you like.
Yep. Yeah, please.
Yep.
And then I can compliment. Yep.
Yep. So in terms of the EXAT and its alignment with other situation assessment tools, the EXAT is the broader tool that comprehensively covers eye care and really is in line with the new integrated people-centered principles that we're moving towards in integration with other health programs, other sectors, strengthening primary community care provision, etc. So that you will find that the tools all align, but there are some more specific situation analysis tools and disease-specific situation analysis tools that are available, and also other situation analysis tools that may be available in the sector as well. And I think they're all very well aligned, and we've made sure that that's the case. So I think you'll find, yes, that they are very well aligned. But if you have any questions, specific questions or comments, please get in touch with us.
Perhaps to add in terms of the concrete SARA tool, because it is a tool to assess the service availability and readiness in countries. Currently, the SARA tool has not a component on eye care and vision, and it is really a broader tool covering all areas of health. We are planning to have a small module on eye care there, but it will not be as comprehensive as the EXAT. So the idea would be to have some information on eye care in a very comprehensive tool from the whole health of the health sector as a whole, but then really we need a specific information on eye care. Then EXAT is the tool, and yeah.
No, thanks for picking up on that one, Alakos. And in a similar format, we have incorporated a key section on eye care within the country capacity survey at WHO, which covers all NCD-related health programs. So we are working towards integrating eye care within these broader surveys. So thanks, Alakos, for picking up on that one. In terms of the vision screening handbook and how it aligns with the primary eye care guidance document that is currently available at in some WHO regions, in particular Afro and also the Eastern Mediterranean region also have some guidance in primary eye care. So it is very much in line with what is included within these documents. However, when we developed the package of eye care interventions, we had a specific focus on reviewing this and updating slightly, I would say, not to take away from the key principles of the existing guidance, but to make some slight modifications. So there may be some very minor modifications between the two. And one thing to add here is that WHO headquarters is in the process of converting written guidance on primary eye care training resources into more interactive training, using the different platforms that are available at WHO and making them much more interactive as opposed to sort of very solid handbooks.
Great, Stuart, thank you for that. And thank you for that last comment. There have been a number of questions in the chat related to how we can turn what you've been talking about into training packages that can be used in institutions. So perhaps when we go out with the slides, we might be able to provide some links to some of those training packages as well, so that we can circulate that to the audience as well. I want to turn to specs, which certainly from my perspective, I think is a really important initiative. I think it's fantastic that you've recognised how important refractive error is and tackling refractive error is, and bringing this community together to really focus on specs. There have been a number of questions. I want to start with one from Donna O'Brien, who's asked, could you let us know if within the WHO specs or other programs, if there is a stream of work on people at the most at risk of eye health inequalities, and particularly uncorrected refractive error? I'm thinking of those with intellectual disabilities who are more inherently going to have a sight problem, also maybe people who are homeless or those with dementia. So I wonder if you could talk a little bit about where specs might relate to that, or where other programs might.
Yep. I can again start just to say that this has been a key theme in the development. Really, specs is to reach, the huge numbers of people in need, but with a particular focus on the marginalized populations where the access is extremely difficult. So this is really one of the key reasons why this initiative is moving forward. And once we flesh out further the different streams and the normative work, you'll see that this is really a common theme that we take into consideration when providing guidance and developing these resources. So that's a general answer, but yes, it's certainly not forgotten, and is important, and especially with the indicators and targets, we're trying to disaggregate as much as possible the information so we can really flesh out and highlight where these inequities are greatest.
Great, thank you. And then another question, which I think is related to specs, which highlighted that the focus that we've been talking about has been access to glasses, the supply of glasses. But the question was, what about people wearing glasses? And I think that relates to, obviously, how do we actually persuade people that they need to wear glasses? Again, it would be helpful to know, is that going to be a focus of specs? How are we going to address that?
Yep. So there will be, if we saw in that third pillar there is it's on all about education, but this also includes prevention and also demand generation, as we know that this is one of the big challenges that we need to address. And also, I think this initiative, really what we're trying to change the focus on building sustainable refractive error services, as opposed to people thinking that provision of spectacles is just this one-off intervention. We know that children, for instance, need to have their spectacles updated every couple of years, and in adulthood with changes as well, we need to have them update. So really, this again has been a key rationale and a key drive behind the scenes with the development of specs and the various areas of technical work as well.
Yeah. Hortense has asked whether we have minimum quality standards for spectacles. And I just wanted to link that to work that I know we're doing on we're beginning on the cataracts side, because one of the things that has come through in terms of those cataract indicators is not just the problems of access to services, but actually that there's a significant gap in quality in many places as well. And so I know that you're beginning work in terms of how do we improve the quality guideline, the quality standards, and how we do that. But I guess that's the same question on the refractive error side, that this isn't just about access, it's about quality. So again, I'd be interested from your point of view, what are the things that we can do both collectively and as in our own individual organizations to improve the quality of what we're doing?
Yep. So I think if we start on the refractive error first and then build on what you mentioned about cataract, as quality is, of course, is an extremely important component. And if you take a look at those country level desired outcomes in specs, there are quite many of them are related to quality, spanning across the services pillar, then the training pillar, and also the surveillance pillar as well. And one of the pieces of work, we recognize that there are very comprehensive standards out there, quality standards out there for spectacles and frames. But making, as governments, as we move towards trying to get governments to take more ownership over the procurement and provision of spectacles, we need to make this information quite digestible to them and quite simple to them. So that's something that we will focus on at WHO and get input from experts on making it quite a digestible piece of information that really spells out what are the minimum quality standards for spectacles and frames. But this then rolls on to training and more standardization of training of health professionals as well. So this is a big place where the sector can play a major role as well. That's on the spectacles front. On the cataract front, you mentioned from the first report, quite a stark finding was that about a third of those people who underwent cataract surgery didn't achieve a good quality outcome. And in this case, the good quality outcome was a vision of 618 or better. So not even 612, 618 or better. So we can imagine this number would actually be bigger if we use the WHO recommended threshold of a good visual outcome, which is 612. So as well as the work on specs, IAPB, WHO are currently working on a range of activities that focus specifically on cataract surgery quality. This started with us at WHO with the package of eye care interventions and really identifying what's the minimum equipment that's needed, what's the minimum medicines and also consumables. Also, we've done a lot of work around defining standardized indicators to monitor quality of cataract, not at the population level, but at the facility level. And there's a new software that's available, a DHIS2 software that's available with an eye care module that includes these indicators. So the uptake of this hasn't been great because it's a new tool so far. So any support also with implementation of this DHIS2 module that not only includes cataract indicators, but other eye care indicators as well is appreciated. And I think this software is also already routinely used in about 80 countries. But the key piece of work that you mentioned before is around the minimum quality standards for to really support countries in planning, implementing and monitoring cataract surgery. So this will be a guidance document that comes from WHO, feeding from the IAPB working group and other experts that are being engaged to really comprehensively cover pre to post-surgery actions and also update the targets for what percentage of patients should we be aiming for to achieve a good, borderline and poor outcome. And the reason I mention this is that there was some targets that are still being used, I think, quite widely in the sector from a consultation that happened in the early 1990s at WHO. So it's important that we revisit these targets and update them. So just a few actions from our side on those two. Yep.
Thanks. No, thank you, Stuart. And I think this is going to be an enormously important area of work, obviously a priority within WHO, but I think it needs to be a priority for us in terms of helping you disseminate and then implement those standards, both on the refractive area and the cataract side. And I think that's something where collectively we will all have a role and all need to be responsible for making that happen. Alarkos, we're almost out of time, and I apologise to the many questions we haven't got to, but I wonder if I can turn to you for a final question, which, I mean, you've talked about the importance of the relationship between WHO and IAPB and particularly our members. But I wonder if you could just say, if you're looking ahead over the next 1 to 2 years, what for you are going to be the real priorities for us in working together, and how can we as a sector really help push this agenda forward? You're muted.
Great, thank you. And I would say really a lot of the same, because I think advocacy is fundamental. So nothing what we have, or the no country action and no grassroots root level action will happen if there is not advocacy. So advocacy needs to continue. And the medical devices is a great example. You know, we can have at WHO all the medical devices in the essential medical devices list. If governments do not know about it, it will not have any impact. So advocacy implementation, look, WHO will not be able on its own to have the impact at country level that is necessary to have, and really having these aspirational targets and moving forward toward those aspirational targets. So really implementation, collaboration is fundamental. Champions, so in whatever people do and what area of work they are, so it's the champion changes the world, and really I would motivate everyone who already, probably of all of you who are here in the webinar, are champions, continue being champions really in that what you do, and moving this agenda forward, and advocating, working, implementing. And last but not least, share experiences, and really tell us also what you are doing in terms of data, in terms of implementation. We always need case examples. We always need really a demonstration of the impact of the work that we are doing also is having at the country level. And if you tell us how you are implementing the tools that we have presented, how you engage in our initiatives at the country level, that will also help us to really bring the agenda up at WHO. And I have put the email address in the chat of vision@WHO.int. So please, for sharing information or asking questions, you can always reach out in that email to us.
Larkos, Stuart, thank you so much. Sadly, we're out of time. I think a lesson for us is we could run this webinar in future for 2 hours rather than 1 hour. We wouldn't run out of questions. I am sorry to everybody who's asked questions I haven't been able to get to, but as I say, we will get them answered and send them out. So we will follow up. And there are a lot of areas which I would love to have talked about, which we haven't had a chance to do. I'm going to make a plug. Come to Mexico, because we're going to hopefully have Larkos and Stuart with us in Mexico. So we'll have 2 or 3 days of them where we can be talking through these questions with them. So as many people as possible who can join us there, that would be great. Larkos, Stuart, thank you so much. Thank you so much for this morning. But I think much more importantly, for your leadership, the momentum, what we've achieved, there is no possibility that would have happened without everything that you've done. I regard the relationship that we have between IAPB, the sector, and WHO as just absolutely crucial. It's right central to what we're trying to achieve. So thank you again. Thank you everyone for joining us, and have a good rest of your day. Thanks.
Thank you.